Hello, good morning. I'm Dr. Yap Boon Tat again. I'm the Senior Anesthesiologist from the Faculty of Medicine and Health Sciences, University Malaysia Sabah. Today, I'm talking about the third lecture of mine for today regarding the anesthesia for lower segment cesarean section, LSCS. Well, I'll proceed further with the elaborations of this. There are three phases of important considerations for anesthesia for LSCS. Phase 1 is regarding the administration of anesthesia, surgical incision and dissection. Phase 2 is regarding uterine incision and the delivery of baby. And phase 3 is about hemostasis and closure. Well, I will tell you more about these phases now. Regarding about phase 1, the events of this as per mentioned earlier, and we have to decide whether you want to give either regional anesthesia or general anesthesia. Of course, the considerations will include whether the mother has been stable hemodynamically and the adequate consent from the patient has been obtained regarding the indication, the complication of GA and regional anesthesia, and the implications of this. Phase 2 is regarding uterine incision and delivery of baby, and in regional anesthesia, informed consent about the complications that will occur during the anesthesia of the mother. And we usually must inform that the patient regarding the baby has been delivered or not, and we must observe the uterine incision and the baby's delivery, and to monitor the volume of bleeding intraoperatively. In phase 3 is regarding hemostasis and closure, and this is a time whereby we must administer uterotonic agents such as Pitocin after the baby has been delivered. Regarding the communication, we must always communicate with the obstetrician regarding the adequacy of uterine contraction. Sometimes the administration of inhaled anesthetic agent like sevoflurane will cause the uterine will not be able to contract properly, and therefore bleeding will occur. And at this phase 3, we must also plan for postoperative analgesia, whether you want to give oral or intravenously for the mother's comfort. Well, in this segment, I will elaborate further regarding regional anesthesia, RA, for lower segment cesarean section. Well, RA is the preferred method for lower segment cesarean section. This is due to the pregnant ladies are more considered to be high risk of aspiration due to their full stomach. And as mentioned earlier, the risk of difficult airway is 10 times much higher than the general population during pregnancy. And anesthetic mortality with GA is 15 times higher than of regional anesthesia. And better maternal satisfaction with regional is the mother is awake throughout the lower segment cesarean section and the improved bonding with the baby. Okay, and of course with RA we can give better pain control like intrathecal morphine or intrathecal fentanyl so that the analgesia will be prolonged post-operatively. Various types of RA can be utilized for lower segment cesarean section. Spinal anesthesia, epidural or combined spinal epidural anesthesia, CSE. In spinal anesthesia, the advantages are rapid onset of dense surgical anesthesia can be produced. It is quick and easy to be performed, and it can be used to perform on the urgent lower segment cesarean section mothers. This will require lower doses of LA, okay, with minimal fetal effects. However, the disadvantages are due to hypotension. Okay, so because of the reduced CSF volume at the epidural space or the spinal space, therefore the higher risk of high or total spinal anesthesia can occur, which will result in hypotension and bradycardia. So this is an emergency whereby mother will usually loss of consciousness and we need urgent resuscitation. Sometimes in spinal anesthesia, we will have inability to add drugs if the anesthesia is inadequate or patchy block. Therefore, we have to convert to general anesthesia in this aspect. In epidural anesthesia, the advantages are because that we have the epidural catheter inside throughout the lower segment cesarean section. Therefore, local anesthetic can be added through the catheter. And of course, for epidural anesthesia, we can use it for post-op analgesia with the usage of additive local anesthetic agent. If the patient develops inadequate analgesia or patchy block intraoperatively, we can top up with local anesthetic agent via the catheter. And epidural has lesser hemodynamic changes such as hypotension or bradycardia as compared to spinal anesthesia. Disadvantages of epidural anesthesia include difficult to insert, and it is time consuming and it needs a lot of expertise in the insertion. Slower onset because of the volume of local anesthetic added will be lesser and will often less dense blockade of the motor and the sensory level. The combined spinal anesthesia (CSA), the condition of which is needed are patients at risk of prolonged surgery. Example, patient has been at the 4th lower segment cesarean section already. So therefore, there's risk of bleeding and the procedure might be longer. Therefore, a CSE is indicated. Patients who benefit from rapid onset of spinal LA, but the exact dose is unclear, especially in morbidly obese patients or with those of a short stature. So CSE must or will be very advantage for these patients. The anesthetic concerns of RA are the need of adequate good surgical anesthesia up to the level of T4, which is at the nipple line prior to skin incision. Difficult to perform due to smaller spinal epidural spaces as mentioned earlier. Risk of high or total spinal anesthesia. Often the patient will present with numbness of the lips and mouth, and then we have hypotension and bradycardia. So this will need urgent resuscitation. Risk of LA toxicity if punctured into the engorged epidural veins. Risk of unopposed hypotension as mentioned earlier, and poor patient cooperation due to the regular painful uterine contraction. So patient will not be cooperative for us to adequately feel the spine, to perform the spinal or epidural anesthesia for her. Patients who are present for anesthesia for lower segment cesarean section, for whatever procedures, we must always take a good preoperative assessment. We must know what are the indications for the lower segment cesarean section. Is it an elective or emergency? And what are her concomitant illnesses that she may have, such as preeclampsia, eclampsia, is this a big baby, macrosomic baby, or any other complications that needed lower segment cesarean section. Of course, we must perform adequate airway and spine assessment. As mentioned earlier, patients who are obese, who are pregnant, they have difficult in airway. So we must assume that the patients will have difficult intubation. Patients should be obtained informed consent about the indication, the benefit, and the complication of regional anesthesia or general anesthesia. Review the latest hematological data, such as we want to know what is the level of the platelet and hemoglobin, and of course we want to cross-match the blood products such as the PEG cells or any DIBC regime in the case of patient with low platelets or coagulopathy. The patients who are present must have at least one IV line which is functionable, and we must run at least 200 ml of crystalloid prior to the performance of spinal anesthesia or epidural anesthesia, so that the blood volume is adequate to prevent hypotension. Of course, we must prepare equipment and resuscitating drugs needed for regional anesthesia and general anesthesia. For drugs needed for regional anesthesia include the heavy bupivacaine 0.5% with fentanyl. patient must be given anti-aspiration prophylaxis such as IV ranitidine, Maxalon or metoclopramide, and oral sodium citrate. So this is to prevent aspiration. So patients, we must perform a good spine assessment, okay, to make sure that we can feel the spine and we are comfortable with the space that we are going to insert our spinal anesthesia, our epidural anesthesia. So usually we can ask whether the patient to lie laterally or to sit up in a position so they can feel the spinal processes and find the interspinal spaces adequately. So usually for patients who are going for spinal anesthesia for lower segment Caesarean section, we can do it around the level of L3 or L4, okay, lumbar 3 or lumbar 4 level. Okay, so these are the preferred place. So the epidural and spaces, therefore when you insert the Tauchi needle for the epidural or the spinal needle for the spinal anesthesia, you will go through these spaces: the skin, the subcutaneous tissues, the ligaments, ligamentum flavum, the epidural space, okay, if you are puncturing into the epidural space, okay, performing an epidural anesthesia. After that, you go through to the dura mater, arachnoid mater, subarachnoid space which contain the cerebrospinal fluid. That is the place whereby we perform this spinal anesthesia and we insert our drugs, that is the heavy bupivacaine and the fentanyl. And then subsequently, if you go through further, you penetrate to the pia mater and the nerve roots. So usually, if we perform a spinal anesthesia, our main target is the subarachnoid space. So this in detail we show where are the layers that are supposed to be penetrated. So if we are going through the spinal anesthesia, we are going towards the subarachnoid cavity or the subarachnoid spaces. The dose of local anesthetics for LSCS is usually depend on the height and weight of the patient, so that to prevent high or total spinal anesthesia. These are totally lesser than as of the normal conventional non-pregnant ladies who undergo any other regional or spinal anesthesia. Okay, so usually we have to titrate according to the height and the body weight of the patient. So such as, let's say the patient is about 170 centimeters and the weight is around 90 kilograms. So you give around 2 mils of the local anesthetic heavy marking 0.5% in combination with 0.2 mils of fentanyl. Okay, so that to increase or to improve the quality of spinal anesthesia. And some institutions, they will add in intrathecal morphine as well, around 0.1 mg, so that the patient will have a prolonged good post-operative analgesia for patients who undergo lower segment Caesarean section. Okay, so intraoperatively during the surgery or lower segment Caesarean section, we must give the antibiotics prophylaxis, whether it's intravenous cefuroxime or augmentin. And then after you administer your spinal anesthesia, we must assess the level of blockade. Usually we want to ensure there's a Bromach score of 1, that is the patient unable to move the knee and legs, and the sensory level is blocked up to the nipple line at the T4 level. Usually an effective spinal anesthesia, you will see the patient will develop a good sympathetic block, that is hypotension. Okay, so after the patient has been introduced the spinal anesthesia, the patient will be supinated and we must put on some monitors such as the NIBP, the ECG, the SpO2 and the capnograph, so that to ensure and monitor adequate blood pressure and the heart rate together with the oxygen level. Give oxygen via nasal prong or face mask so that there is a continuous or good oxygen flow to the fetus. And of course, we must watch out for bleeding during the surgical incision. And once the baby is out, we give the intravenous pitocin about 5 units to encourage the uterine contraction and to prevent bleeding. So this is the third part of my presentation regarding regional anesthesia for lower segment Caesarean section, and I hope that all of you will benefit from this talk for today. Signing off, I am Dr. Yap Buntat from the Faculty of Medicine and Health Sciences, University Malaysia Sabah.